Howdy, here we are again. Aaron Boster here, and it's another night when I'm not getting a lot of sleep, and I wanted to see as an experiment whether or not you guys are still online. The other night I jumped on, and much to my surprise, there was a bunch of folks from this village that were all up and about, and I had a really fun time talking to you, and I wanted to try it again. Now I'm trying to get some stuff organized here. Let me see if I can change the angle a little bit. There, that's what I want to do. Hey, I like pie. I like pie also. How are you? As you guys jump on, please tell me where you're coming in from. So just tell me, what part of the world you're coming from. And if you have questions about multiple sclerosis or about COVID and multiple sclerosis or what have you, or you just want to talk to a MS neurologist who can't sleep at night for the moment, throw me a question. I would love to answer it. Make sure when you ask questions that they're general questions. I can't really diagnose you or treat you on the interwebs. I've got Carl from Utah who's here. Margaret, we got Riley from South Carolina, Emma from Ohio. Go Emma. This is fantastic. Folks from New Zealand, Long Island, Boston. This is fun. Howdy, everyone. We've got folks from New Jersey, from Florida. Go ahead and rub it in, Cheryl. You have better weather than I do. This is really great. Thank you, everyone, for jumping on. There's 43 of you online already. Good. Again, this is not a paid promotion. I just really like that stuff. Sparkling water. I've got someone from Saudi Arabia. Howdy, hi. Chicago, Melbourne, Australia is in the house. We've got Colorado. This is fantastic. Texas. It's so much fun to be part of a growing global online community. When I started this YouTube channel 6 years ago or something like that, I wanted to energize and empower and educate, but I didn't know that there would be this awesome community. I just love this. So I got our first question. Hey, Francois here. I haven't talked to you in a while. How are you? Question is, how far from rituximab infusion should I take the vaccine? So Rituxan is a B-cell depleter, and it's a medicine which is typically given every 6 months. So the way I interpret the question is between my infusion and then 6 months later, my next infusion, when's the best time to get the vaccine? The real answer is we don't know. Now, the logic that we've been applying is from other studies studying other vaccines, with ocrelizumab, a study called the Veloce trial. And what it suggested was it worked best if you waited, so about 3 months in, then you got vaccinated, you still mounted a response. It was just attenuated. And so we applied that logic to COVID. Now, the data is slowly coming out, and it's not really clear. In one study, at least, they immunized people at different points in time. This is with another B-cell depleter called Ocrevus, and it didn't really seem to matter when they were immunized. And so I think the question is really unanswered to date. What is my opinion? My opinion is you get immunized when you're given the opportunity. So here in the United States, as they rolled it out, if your lot was called and you were able to get vaccinated, I want you to, even on a B-cell depleter, because I want you to make T-cell response against COVID. So even if the timing wasn't right, you're still going to mount a T-cell response, and that's going to provide some degree of protection. Great question. So lemon peel angelfish, howdy do? Question, any advice on someone changing from Tecfidera to Tysabri? So not really. I think that's a very easy transition in my experience. When I've done that, it hasn't been a big to-do. You think about how Tecfidera works. It tricks your cells into thinking they're under oxidative stress. So then they make this antioxidant cascade of loveliness, which slows MS. Tysabri works at the level of the blood-brain barrier, tightening the blood-brain barrier so that cells can't get through. So that's really different. And Tecfidera doesn't last in your body all that long. So a couple of days after you stopped, it's kind of getting out of your system. So typically what I've done is I just stop the Tec when I start the Tysabri. Now, of course, you have to talk to your doctor about the right thing for you. But nonetheless, I think that, at least in my experience, it's pretty easy. So Ichabod 13 is in the house. Hey, how are you? Guys, if you like this format, give me a thumbs up. So give a thumbs up, and that'll tell me that you're loving what we're doing, and it helps out the channel analytics. So Tiffany is here. Hey, how are you, Tiffany? Mohammed, would you be able to give your opinion on tolebrutinib and how it might compare to Ocrevus. Yeah, I can do that. So tolebrutinib is a BTK inhibitor. So what's that? Well, that's a pill which currently is FDA approved for some cancer indications. But early studies look like it might be a really rock star drug in the setting of multiple sclerosis. And I'm actually involved in some clinical trials studying that drug right now. And we're studying it in relapsing multiple sclerosis, so people with MS who have attacks. And then we're also studying it in primary progressive multiple sclerosis, so people with PPMS that aren't having attacks from the get-go. And we've enrolled patients into both, and it's really exciting. Now, this drug, this BTK inhibitor, is a small molecule, it's a pill, and it works in a weird way. It blocks B-cell transmission without murdering B cells. So Ocrevus is a B-cell depleter. So like Ocrevus, Kesimpta, Rituxan, they kill B cells, which is a great way of treating MS. The BTK inhibitor doesn't cause murder, doesn't kill the B cells, but it like makes it so you can't hear them. So they can't propagate a message without making them die. The other thing that this molecule does, because I think this one is brain penetrant, it can actually get into your noggin, is it can interfere with activated microglia. So microglia are these cells in the brain that are involved in the immune system. And when they turn on, they eat stuff. And sometimes in the setting of MS, they eat stuff they're not supposed to. And this drug seems to turn them off or make them chill out. So I kind of think of like the Incredible Hulk, and you just calm him down, and then he's, Bruce Banner again. And so the drug's kind of exciting. And one of the things that I think is exciting about it is it doesn't have a significant infection profile. Now, in the trials, relapsing MS, we're comparing it against Aubagio. And in PPMS, obviously, that's not the case. It's compared against a placebo. And we don't know how it's going to fare against something like an Ocrevus. I think I can't even gander a guess. Ocrevus did a really good job at inflammation, both in relapsing and in primary progressive MS. I'm talking about the OPERA trials and Oratorio. And I'm not really sure yet. Mechanistically, this drug sounds very exciting, particularly in PPMS, because of working on the innate immune system and the way it works on the humoral immune system. So here I am being a super nerd at 11:11 at night here in sunny Ohio. So sorry for the long-winded answer, but I think it's a really cool compound, and I'm very, very excited to be studying it right now. Thanks for the question. So Paul says, what do you think about the potential of higher dose Ocrevus to scrub lesions? So I don't know about scrub lesions, but I think higher dose Ocrevus is a great idea. And there's actually a clinical trial ongoing right now looking at high dose Ocrevus. I suspect we're going to find it's better. I think it'll be a more impactful way of giving the drug. So I'm very excited about that. So there's about 81 of us jumped online. If you like what's going on, definitely give a thumbs up, guys. I'm just answering some questions about multiple sclerosis. If you don't know me, my name's Aaron Boster. I'm an MS neurologist in Columbus, Ohio. I'm the founder of the Boster Center for MS, where we care for folks with MS from around the globe. And I love interacting with this YouTube growing online community. So as you jump on, tell me where you're logging in from, because that's super fun to read. And if you have questions, throw them in the chat. LC says, question, are infusions safe? Are there any issues with taking steroids before infusions? So saying are infusions safe is like saying like, is construction safe? So you can be in construction and you could do like plumbing, or you could do construction and do like carpentry. They're very, very different, and they have different risks. And you can't really talk about infusions as just the way that you receive a medicine. And each medicine has a different mechanism of action and a different side effect profile. Now, you make reference to giving steroids before an infusion, and that's done in some infusions, not all, to help you tolerate the infusion better. So it's called pre-medication. So for example, with some of the MS medicines like Limtrada or Ocrevus, we give steroids before we give those medicines, and they make you tolerate the medicines better. Great question. All right, there's 94 of you on MS Water Challenge. So if I drink, you drink. So if you've got your water nearby, let's do it up. And let's see, Robert's calling in from California. 32-year-old, these tremors are the worst part of my MS all day, regardless of propranolol. So tremor is actually a really hard symptom to treat. My heart goes out to you. Sometimes if you're having a really difficult time, you may talk to a movement disorders specialist. I've had really refractory tremors that I had trouble treating, and I would send them to a colleague in movement disorders, and they helped me come up with some options that I hadn't thought about. Just food for thought. So Danielle says, "Sir, why are you up so late 2 nights in a row?" Laugh out loud. I don't know. There's a lot of exciting things going on in the clinic, and I got a lot on my mind. It's not a bad thing. So Nexter says, doesn't have a question, but wants to say good night. Good night, Nexter. I hope things are awesome for you. And whoops, I'm skipping all around. Sorry, guys. I am not awesome at managing the chat. So Donna Bolt writes, how long is a symptom considered permanent? I've had numbness since August. Switched to Tysabri in January. Finally, no active lesions since June. So first of all, that's awesome news that you don't have new lesions or activated lesions. And second of all, good job going on to Tysabri. It's a fantastic medication. I really think it's highly efficacious. As far as how long symptoms last, I assume you're talking about having an attack and then some symptoms from the attack, and then how long does that last before you say, okay, it's permanent? And it's variable. Generally speaking, if you have a symptom at 6 months after an attack, in my experience, a lot of times it's going to be there. And even more so, a year after an attack, it's definitely going to be there. That stated, I have seen exceptions to that rule, but I would assume that if it's 6 months or a year later and it's still there, that might be something that you're stuck with. Now, the other piece to this is you can treat symptoms. So let me take an example of an MS attack, a sensory attack where you felt like your arm was on fire, which would be horrible. And let's say that we treated it with steroids and over some time, and now it's down to 10%. So it's still very uncomfortable, but it's not like it was burning beforehand. And that might become a chronic symptom, but I'm not going to recommend that we just allow you to be like that. So we would then use symptomatic medicines like gabapentin, Neurontin, Lyrica, pregabalin. We'd use Topamax, Tomirabate, or Cymbalta, duloxetine, Elavil, amitriptyline. All those medicines I just listed might treat the neuropathic pain. And so we would be able to dampen it. So that's kind of how I would think about it. And I hope that those symptoms go away. So Jen McGraw writes, now no, spine lesions aren't silent, but how do brain lesion localization affect someone? For example, i.e. classic spot like Dawson fingers. So when you go to neurology school, they spend a really long time teaching you if you have these symptoms, then that localizes to this spot in the brain or in the spinal cord. And it's kind of cool to learn how to do that. It's called lesion localization, and I really enjoyed doing it. MS doesn't really care about lesion localization. And the reason is that if there is an opportunity to work around, your brain will. The damage in MS is not caused like a stroke where that area gets blood supply cut off and just dies. It's inflammatory, and it happens not suddenly, but slowly over hours to days or to even weeks. And that gives your brain time to rewire. So you may have a lesion, but not have a loss of function because your brain just worked around it and didn't tell you. Now, one thing that I do like to keep in mind is as you have these lesions, which are brain damage, so as you have spots of brain damage, and as your brain's trying to rewire itself, you're using more and more brain, more energy, more tissue to try to get the job done. And if you give an example, I did a study a long time ago in a functional MRI machine where we could measure what parts of the brain were activated, which is really cool. And in the scanner, I would have someone do this. And in a control patient who didn't have MS, just this part of the brain would light up. So that's the motor strip. And then we'd put someone with MS in the scanner, and they would do this every bit as fast as the other person, but both hemispheres would light up. And I really think that's the underpinnings of fatigue. Because when you're doing something, you're taking a lot more brain to get the job done. And so that's what I think of when I see a heavy lesion burden, is some of these chronic symptoms like fatigue and cognitive fatigue and stuff like that. That's a good question. What else do we have going on, guys? Debbie Bell writes, what can I do to stop a Charlie horse cramps? They are bad in the morning. My feet and legs are painful. So stretching is your very best friend. stretching so that you don't get cramps. So I would stretch in your bed before you exit your bed in the morning, or before you exit your bedroom. Stretch out your calves, stretch out your hamstrings, your quadriceps, your butt, your hips, your back. And then I would do that again before I get into bed. So you do it like before you leave your bedroom in the morning and before you climb in your bed at night. Then just do it once during the day. And I find that if you do that, you're constantly stretching out your calves. It decreases the frequency of Charlie horses. Also, seeing how long you can sit before you cramp. You might say, hey, I can sit for an hour and I normally don't have a problem. But if I go 2 hours, I'm highly likely to cramp. Well, then just remember that once an hour, you need to get up and walk around. Making sure that you're hydrated, by the way, MS Water Challenge. Staying really hydrated can help cut down on cramps. Making sure that, that you're not dehydrated is a good idea. And there's lots of medicines that can help with cramps. But let's leave the discussion of medicines for another day. So there's 114 of you online. If you like what we're doing, give a thumbs up. Just want to exit out of the chat, hit thumbs up, then jump back into the chat. Let's see what else is cooking here. Let's see. Hello, my fellow MSers, Claudia says. There's lots of stuff going on here. Hello, Doc. Hello from Alaska. That's pretty neat. Sarah's in Ohio. Hey, me too. Lisa writes, do you foresee medication in the future that will help those with PPMS once those patients can no longer walk and have other comorbid conditions? Yes. Excuse me. So right now, there is an FDA-approved medicine, ocrelizumab, which works in PPMS and has been shown to maintain thinking and memory, brain volume, and hand function in people that are non-ambulatory. And so we have a drug that can do that. And I think that we will have more. As I mentioned a little bit earlier, telebrutinib is this BTK inhibitor that we're currently doing a clinical trial on in hopes that it can help in PPMS. So there's several other investigations looking at options to treat progression, whether that be primary progressive MS or secondary progressive MS. And I think that there's some very, very exciting things coming down the pipeline. So more to come over the next couple of years. Stephanie writes, I love how you explain everything. You make it easy to understand. Well, thank you. It's my contention that if I can't explain it, then I might as well not know it, because I don't treat people as a doctor by cutting them or by doing something to them like a surgery or a procedure. I try to help people by request. So I say, like, would you please not smoke cigarettes, or would you please exercise? And if you don't understand why I'm asking you to do that, then you are unlikely to do it. But it's my opinion, if I can get you to understand why, you may just do it on your own. And then we both win. So thank you very much for that. So Lemon Peel Angelfish says, my husband is wondering when you sleep. So my grandma used to say that I'm not a very good sleeper. And she was right. I'm not a very good sleeper. Dylan writes, what's your thoughts on stem cell research for MS? And I like the way Dylan phrased that question. I think stem cell research for MS is awesome. Right now, Jeff Cohen up at the Cleveland Clinic is doing a really cool stem cell transplant study. And I think that that is exactly where stem cell transplants in MS should be, in research. I do not buy into stem cell tourism. And I think that there's predatory behavior around, and sometimes things are dangerous. And stem cells are nothing stem cell transplantation is nothing to joke about. It's nothing to do lightly. There's risk with doing it. And I think that's a really good idea to do it within the context of research. So great question. Thank you. Hello from Palmer, Alaska. Alaska is definitely a place that my family would like to visit again. Sarasota, Florida is in the house. DeWitt, Michigan. Go Blue. Cotaline. Je ne sais pas où ça c'est. Ça c'est en France ou d'autre part? Carrie and Nancy, I am with you on SPMS and Ocrevus, logging on from Utah. This is great, guys. Teresa writes, hi from Mississippi. Love your videos. Well, thank you. I was diagnosed with RMS at age 60 back in the winter. What is the rate of progression for us seniors living with MS? I'm on Ocrevus. So onset of MS in 60 is unusual, but can happen. The most common onset is at age 30. So 60 is a bit older than 30. And similarly, we sometimes diagnose children with MS. It's kind of like a bell curve. And so progression after the age of 40 can tend to be a bit faster. Now, I love reading that you're on Ocrevus, and that's fantastic. And that's a highly effective medicine, which is good at slowing the risk of attack and new spots, but also in slowing brain volume loss and disability. And so that's really fantastic. I think that instead of worrying about like the rate of progression, I would want you to be 5 for 5, right? I want you to be on a medicine, make sure it's working. And you started Ocrevus, and so you'll monitor that. That's awesome. I want you to exercise as part of your lifestyle. I want you not to smoke stuff. I want you to supplement vitamin D. And I want you to once a day to practice mindfulness or exercise. So next year you got your water, buddy. All right. So what else do we have cooking here? Howdy from West Virginia. Well, hello, Linda. Robert writes, if MRIs are only 90% effective at finding brain lesions, and the diagnosis is partially dependent on finding MRI lesions, does that mean 10% of people with MS never get treatment? No. So first of all, I don't know where you come up with the 90% effective. So that's not true. So an MRI is not effective, or it's not a therapy. It's a diagnostic tool. And it's not 90% effective. If there's a lesion, it'll see it, particularly with high field imaging. So when you look at a 3 Tesla MRI properly protocoled, you can't hide anything as long as you're doing contiguous cuts. Now, the diagnosis is dependent on a set of criterion, which include clinical history, exam findings, and MRI, and sometimes spinal fluid and laboratory testing. So it's not just the MRI. It's my contention that if you have MS, I should be able to prove it. And one of the ways that we can do that is through MRI. So I'm not sure where you came up with that 90% figure, but thank you for asking that question. So Jen writes, how do you know if progression is taking place, especially when first diagnosed? And many of the symptoms have occurred before a neuro following. So sometimes you can only figure out progression looking back. So I used to golf twice a week competitively, 18 holes. And then a couple of years ago, my friends didn't want me to compete with them because I couldn't keep up. And then I only golfed once a week with my wife on Saturdays. And then for several years, I could only golf 9 holes. And this is the first year in my adult life I don't own a golf membership. A story like that, which is like a slow, steady decline, is what we're listening for in the setting of progression. Early on in the disease, we're not so much looking for progression as we are for attacks, resolution of attacks and chronic symptoms that we're trying to treat. It is difficult. It's oftentimes something that you can only see with a retrospectoscope when you look backwards. So Sarah says, question, is stem cell therapy the same as cord blood? So when you have a baby delivered and you have the umbilical cord, there are stem cells inside the umbilical cord. And so you can extract those stem cells, and they can be used for, in some cases, stem cell therapy. And so it's not the same thing, but they're related, and I can understand why you'd ask. So Lisa's rooting for the Spartans. All right, Lisa. What else do we have cooking here? So Ali Uncharted, which is a cool name, writes, do you think there will be a one-size-fits-all cure for MS? No. Or is the process that will require steps to be fully effective? So I don't think there's a one-size-fits-all. First of all, we don't understand everything about MS. We're still actively learning, literally. And I think there's a lot of learning that needs to occur before we conquer this disease. I've said this on other videos and live streams, but I think it's going to take a multi-pronged approach immunologically and neurologically. I think we need an anti-inflammatory agent, which we currently have like 25 different flavors of anti-inflammatory agents approved by the American FDA. These are the current DMTs. In one shape or form, they quell inflammation. So that's important, but that doesn't cure MS. That doesn't treat all the things we need to treat. My buddy Gavin Giovannoni talks about the smoldering MS, sort of the slow burn in the background. He calls that the real MS. I think it's an aspect which we haven't been able to tackle very well yet, in part because we don't have the other 2 therapies that I think we need to bring to the table. One is a remyelinating agent, and we're still actively trying to find one that works. So far, we've had a lot of negative trials. It's really a bummer. And the second thing is a neuroprotective agent. And we don't have those other 2 things yet. So I do think it's going to be a multi-pronged approach. I don't think it'll be a one-size-fits-all. Rachel says, great chat for all of us here, and especially for me, as I just finished an Ocrevus infusion today. Joe writes, will 1.5 Tesla MRI be sufficient for lesion detection with or without GAD? If the lesion detection, if the MRI is set up with an appropriate protocol, yeah, very likely, yes. So you can see more with a 3T. This has been studied. And when you image someone with MS and a 1.5 and a 3, there are lesions that are much more clear on the 3 that you could miss on the 1.5. But a properly protocoled 1.5 will give very, very good images. So I don't think it's a complete deal breaker if you don't have access to a 3T. If you have access to a 3T, that's definitely my preference. I think it's a higher likelihood of seeing everything you need to see. So Luth Don writes, question from Central New Jersey. Do you feel that MS is over, under, or properly being diagnosed? I think it really depends on the region and who's doing the diagnosing and stuff like this. A lot of times there's been some papers that suggest that upwards of like 10% of people are misdiagnosed. So they're given an MS diagnosis when they don't have it. And I definitely think that oftentimes there's a delay from symptom onset to diagnosis, which can be years and years because it's misdiagnosed. So I think it depends on the region. I would like to think that at centers of excellence that they do a better job, but I don't know that that's necessarily true. And the key is to use the diagnostic criteria. So we have some very good criteria that are universally accepted. The 2017 revised McDonald criteria, and we really want to make sure we're using those criteria when we diagnose. And that'll help eliminate the risk or the higher risk of false diagnoses and missing stuff. So Seek and Find writes, is Mayzent a good medicine? Yeah, Mayzent's a good medicine. Mayzent is a pill. It's in the family of Gilenya and Zeposia and ponesimod, but I can't remember the trade name for ponesimod right now. And it's an S1P1 receptor. I think those medicines are really solid at decreasing relapses and stopping new spots on the MRI. And I think that they do a decent, not amazing, but a decent job at slowing progression. So I think that's a fine drug. Whether it's a fine drug or not, however, you're going to be able to assess its response over time. So telling your clinician if you're having new disease activity or failing a litmus test of life, getting MRIs once a year probably, having neurological examinations and testing, and making sure that we're not losing ground, we're going to make sure that that Mayzent or whatever drug you're on is working. So another LaCroix. Lisa writes, is there a genetic component with MS in siblings with other autoimmune issues such as myasthenia gravis, fibromyalgia, and arthritis? Yes. So if you have MS, someone in your family probably has an autoimmune condition, and it doesn't have to be the same one. And that might not be a sibling. It could be a cousin or an uncle or aunt, but typically you'll see that there's clusters of autoimmunity in the family. And also, if you have one autoimmune disease, you're more likely to have a second autoimmune disease. So you're spot on. That is very possible. So Kay Swinson writes, I travel 1 hour to see my neurologist. I'm planning a long road trip to see Dr. B in the new year. I can't cope with getting worse. Well, that's very, very kind of you. I'm not magic, but I do try really hard. And I love the fact that we're now opening up to letting people come in the office. So we're largely letting people come in the office if they've been vaccinated and if they need a procedure or an infusion. And we're still taking significant precautions, but it's so nice to be able to see people face to face. I miss that. There's some people that I haven't seen face to face in a year or more. And so now I'm getting to see them, some of them in clinic, and that's really cool. So there's 145 of you online. That's really super awesome. There's 89 thumbs up. So if you like what we're doing, jump out of the chat, hit thumbs up, and jump back in. It helps the analytics and tells me that you dig it. And so Shannon writes, we banked my daughter's stem cells, and we would be something for me to look into for myself and using them. So that's a choice that folks can make. And you can actually, at the time of birth, have those put on ice. And then you pay a fee and they maintain them for you. And I think that's cool, Shannon. So ALAA05166 writes, is Ocrevus improve hand function more than leg function, and why? I don't think it improves hand function more than leg function, but Chariot MS are looking at folks that are wheelchair bound and demonstrating that they maintain hand function longer. And so there's a neurological reason why legs seem to be more impacted than arms. And that's because it's not the arms or legs that are being impacted in MS, it's the spinal cord that controls the arms and legs. So here's your brain and then the spinal cord. The spinal cord down to here has all the information that then go to your arms. And there's information for your legs. And then all the information for your legs keeps going down until it gets to the part where it branches off for your legs. So if you randomly hit the spinal cord with lesions, randomly, there's a higher likelihood you're going to hit areas that cover the legs more than the arms. And so there's a preference in MS. You can see leg involvement more often. I hope that made sense. So Leslie writes, can eye floaters and light flashes be MS related? Not generally speaking. An eye floater is an ophthalmologic thing where you have some debris floating in the anterior vitreous fluid. It's not really related to MS directly. Lemon, peel, and fish, says Dr. Boster. You're magic and awesome. That's very nice of you. I don't think that's true, but that's very sweet. Linda writes, how do we control the MS tremors? When a new patient comes to see you, do you think it is necessary to order a new spinal tap or the results of previous one enough? Two good questions. Let's answer them in reverse order. So to make an MS diagnosis, we follow that criteria that I was mentioning. And you don't need a spinal tap to diagnose MS. So if I am able to make the diagnosis by history, physical, and MRIs, I don't need an LP. In Europe, oftentimes they tap everyone. I'm told. In the United States, I don't think it's done everywhere. I don't think it's always necessary. And so if someone has LP results and they're positive, I'm not going to repeat that. If it's negative and if there's a really important question, rarely we'll repeat it, although I wouldn't say that's a standard practice. The reason is because 90% of people with MS have changes on their CSF at some point in time. And so if it was negative years ago, it is possible that it could become positive later. Good question. So let me just have this person removed. All right, we'll do like that. That should help. Okay. Sorry, guys. So what else do we have here question-wise? What DMTs do you recommend for women considering pregnancy soon? Oh, that's a great question. I know many drugs need a washout. So pregnancy in MS is a very common thing, right? So most people with MS are women and the average age of onset is 30. So a lot of folks are of childbearing potential. And I always teach my trainees, you need to ask about pregnancy when you meet someone, like, hi, when do you plan to have children and whatnot, because you have to plan. And so there's a lot of different ways to do this. So back in the ancient days of yesteryear, we said you have to stop all of your medicines. And I don't love doing that. I don't do that anymore. And then for a while, we realized that it's safe to use Copaxone in pregnancy. So we would allow a woman to continue on Copaxone through pregnancy. And more recently, we have great data that staying on the interferons is actually safe. And so there's other things that you can do. We're getting a little bit off label, but I'm very comfortable allowing a woman to become pregnant on Tysabri and then stopping the Tysabri after the first trimester. There's windows of opportunities to become pregnant while taking 6-month Ocrevus infusions. So my point here is there's different ways of slicing and dicing things. We have to think about what you're on and what the game plan is. And the important thing is to have an open discussion and an open dialogue. You really want to be very planful with your neurologist and with your OB-GYN. Kyle writes, question, can PPMS cause new allergy symptoms? I don't think so. I think of allergies as a peripheral phenomenon and MS as a central phenomenon. And I think it could be true and not related. All right. Don't you sleep, Dr. B? Well, yes, Becky G, I sleep. Just not at this moment. Actually, back when I was in college, I didn't sleep very much at all. And I would routinely go to bed very, very late. And I knew that if I heard the birds chirping, that I had stayed up too late. So Rakesh If I said that wrong, I apologize. My son has inactive SPMS. His neuro is given up on treatment. What are the treatment options we could consider? So thank you for that question. And SPMS, secondary progressive MS, is a form of relapsing multiple sclerosis. So SPMS means that you've had relapses and you could still have relapses. And the medicines that treat relapses also slow progression, and they slow brain volume loss. And I want all those things. So point is, if you have SPMS, you could have an attack. It's maybe not as likely, but it still could happen. And you are certainly at risk of progressing and having brain volume loss. And so being on a medicine to me is the only thing that makes sense to slow that down. There's a lot of different options to do that. Excuse me. Shannon writes, if it's shown to slow progression during pregnancy because of the levels of hormones, why don't females take large amounts of estrogen? So this has been studied. There was a trial where we gave women estrogen and Copaxone in hopes of recapitulating a pregnant state. And it didn't really work as well as we wanted. There's also risks of having ultra high levels of estrogen for long periods of time. So it's not as easy to take advantage of that as we hoped it had been. Sharon Grossman writes, what's the difference between SVID and MS? If they both affect the brain and have the same kind of symptoms? From Cincinnati. Well, howdy. So SVID stands for small vessel ischemic disease. And it's not a disease, actually. Small vessel ischemic disease is an appearance of the MRI where you see little white dots, and it's typically in a portion of the brain between the ventricles and the cortex. So it's called the subcortical white matter, right? And it's typically in the frontal hemispheres, and it's typically not in the base of the brain. And that's typically asymptomatic. So I don't understand your comment about the same symptoms, because that's not true. MS is very different. MS is caused by demyelination and inflammation. The lesions have a different shape, a different size, and importantly, they have a very different location. So fortunately, sorting out SVID, small vessel ischemic disease, which is just an appearance on the MRI, and MS is super easy in my opinion. Good question. Rachel Goldberg writes, what can I do to try and prevent my children from getting MS? These are great questions. So Rachel, you point out, if you have MS, your children are at a higher risk to develop MS. So here in sunny Columbus, Ohio, the risk for MS in the general population is 1 in 350. And if you have MS, it's more like 1 in 40 for your children. And there's some things that we know can increase the risk for your children, and some things that we can do to lower the risk. So we want to do the ones that lower the risk. So there's some evidence that allowing your children to be morbidly obese or to be inactive can double their risk to get MS. That if they're exposed to smoke, it can increase the risk to develop MS, almost double it. And if they have low levels of vitamin D pre-puberty, it can increase the risk to develop MS. There's some question about high salt diet. I don't have enough information to tell you that's a good idea. There's definitely a risk associated with EBV, or mononucleosis, the kissing disease. And although that's kind of hard. So some of those you can control. You can avoid tobacco exposure. You can make sure your kids are physically active. You can supplement vitamin D with the supervision of their pediatrician. Those are all things you can do. Avoiding mono is like near impossible. And I don't think there's enough data for the salt diet to maybe deny children, potato chips. So Angela writes, what medicine would you recommend for someone who is severely scared of medicines? I have PPMS, and I've been becoming more disabled since diagnosis. I don't have relapses. So for PPMS, there's one drug that's been proven to work, and that's ocrelizumab. That's an infusion twice a year. I think it's a really great therapy for PPMS. I was involved in the Oratorio trial that led to its approval, and I use it a lot with PPMS patients in practice. Kyle throws up some hearts. Thank you. Oh, Mike is on the line. Mike's one of our awesome moderators. Mike, how are you doing? How do I get my balance back? He writes, will it ever come back? So balance is a tough one, and you can retrain balance. Now, there isn't a pill for that ill, but there's therapy for it, physical therapy in specific. And so if you check out the channel, I have a playlist on multiple sclerosis and balance. And I have several videos where I talk about balance and MS. And so definitely check that out. And you can work with a physical therapist, particularly a neuro PT, and they can help you retrain your balance. All right, what else do we have cooking here? How common is it for someone with MS to have an ANA titer? It's actually very common because sometimes autoantibodies can trigger a false positive on that ANA test. So you definitely can see that. Cy-D writes, in general, how well do patients on Ocrevus function on dialysis with a kidney transplant? I don't know that I've cared for someone with a kidney transplant or with dialysis with Ocrevus. Now, Ocrevus isn't metabolized by the kidney. It's a drug that's catabolized in the bloodstream, but I can't actually answer your question. That's a really good question, and that's going to be my homework. So you stumped me. Thank you. So Dainty Living Large, that's a cool name, says hi from Ohio. Is there a medicine to help with dysphagia? So phage is Greek for eat. Dys means not so good. So dysphagia is problems eating and swallowing. And there isn't a medicine, but there's therapy. There's speech pathology can help teach you ways of swallowing safe, or give you recommendations for the kind of foods that are safe to eat, or thicken liquids and things like that. Joe writes, is there medicine to help with this? Oh, I'm sorry. I just read the same question site twice. Sorry, Joe. All right. Bluebird writes, when my children were little, I read that extended breastfeeding could reduce the child's chances of getting MS. So I did that. Is that true? I don't know that that's true. Now, there are some benefits we believe to mom. It decreases risk of attack, at least in 2 of 3 trials looking at breastfeeding. And it's super wonderful for passive immunity for your children. I don't know about it decreasing risk, to be frank. Robert McDaniel writes, I've had severe mono in 3rd grade and raised by a smoking father. At 56, I'm a disabled now. Would high-dose Ocrevus help? Separate questions. So you're sharing some of your risks that we just talked about amongst children. The question is, would Ocrevus help someone who is severely disabled? I'd have to have a better sense of a lot of different factors, but it's not something that can only work in early diagnosed people. The disease-modifying therapies may have less of an effect as we get older, potentially, but that's still of value in my opinion. So would I tell someone at 56 that they shouldn't take a therapy? Never. Would I tell someone who's severely disabled they shouldn't take a therapy? No, I would not say that. Becky G writes, I asked my doc if any blood work is needed prior to my first full dose of Ocrevus, and he said no. What is your general rule? I agree. So Mike Jacobs writes, is there anything besides modafinil that can help with MS fatigue? Yes. And so I have a playlist on my channel on fatigue with a bunch of videos. I mean, 20, 30, I don't know, a bunch of videos. I made a lot of videos on fatigue because it's the most common symptom in MS. And so there's bunches and bunches of things you can do. Now, if the question is about medicines, levocarnitine can help with fatigue in some people. Modafinil, armodafinil is a newer version. Adderall and the other stimulants like Focalin and Ritalin and Vyvanse, all of these can be very, very helpful. Amantadine in some patients can be helpful. So there's things we can try. So Kathy Keats asked, question, does Mavenclad wipe out the COVID-19 immunity? No, Kathy, it does not. In fact, it's a really interesting study that was done by this Dr. Acheron in Israel that showed that it doesn't matter when you take Mavenclad, that if you have a COVID vaccine, it seems to work. Well, the Pfizer COVID vaccine, it seemed to work. That's really cool information to have. Holly Ann Owen writes, can you have lesions that are too small for the MRI to pick up? It depends on how good the scanner is and how good the sequences are and how well it's protocoled. But that would be kind of hard unless you're having gaps between your slices of your MRI. Rebecca writes, how could I have trigeminal neuralgia when MRI shows no lesions on the nerves? So you can have trigeminal neuralgia from a central lesion in the brain or anywhere along the nerve, or it could just be pinching where it leaves the skull base. So there's a lot of different options, unfortunately, in the setting of MS. Debbie Wood writes, are DMTs considered chemotherapy? No. Some disease-modifying therapies are immunosuppressants in nature, so they work by suppressing the immune response. And some of them can be used to treat cancers because they do that, but they're not traditional chemotherapies. They're biologic agents. when I think of the word chemo, I think of the 1980s and like Cytoxin and just like, killing all the cells. And these drugs are highly selective. So the word chemotherapy doesn't really have the same connotation anymore. All right, guys, we've been online for 45 minutes. This is super fun. I'm going to answer another question or two, and then I'm going to try to hit the hay. And I want to thank all of you again for this opportunity to chit chat with you. I love these questions. If I didn't get to your question, don't fret. I'll go through the chat feed and pull out questions I didn't get to, and I'll try to answer them in future videos. And if it's not on another live stream, I hope you see you on a Monday video, or the best thing if I got to see you like at the MS Center. That would be really cool. Let me answer a couple more questions here. Can you share some information about Mayzent? I did that a little bit earlier in the live stream, and I have a video or two where I talk about Mayzent. Rachel Tate writes, I had one lesion on my cerebellum in 2006. I've not had other lesions since. I have positive spinal fluid, all MS symptoms. Would you diagnose me with MS? That's nowhere near enough information. I would need to review all of your records. I would need to talk through your history with you. I would need to do a formal, thorough neurological examination. I would need to look at all of your imaging. I would need to look at your spinal fluid results and all your labs. And only then would I be able to answer your question. That typically takes me a couple hours to go through all that. All right, so wrapping up, good night from Australia. Lana says, you guys are fantastic. I super appreciate this village and this growing global online community. I'll jump back on soon, and everyone be safe and have a wonderful night.